Diagnosis and Treatment Planning, a Prosthodontic Perspective. As the title shows that today's lectures will focus on to tell you from a prosthodontic's viewpoint how we do a diagnosis and a treatment planning for each patient walking in the clinic. So prosthodontics is a specialist. The record shows that less than 2% of the dentists in the States are the prosthodontists. So the prosthodontist actually is to treat all the patients need, for example, like dentures, partials, or implant restorations. So first, we have to know what's included for the treatment sequence. So the whole treatment sequence actually be divided in 3 different phases. First is about the data collection. The second is about diagnosis and treatment planning. The third is about the surgery and prosthesis. So the first one is about the data collection. The data collection means that you will take all the records to figure out what's the problem that the patients carry on. So after that, you will use those information to come out the diagnosis. After you have the right diagnosis, that you will do a treatment planning. All treatment options were related to the diagnosis and the problem list as you found out when you do a data collection. And the last part is that after you have a treatment plan, you follow that to do the procedure like the surgery or the final prosthesis, and finally to solve all the patient's problems in the end. So when we do a treatment planning, a patient will ask a lot of questions, but one question will always comes out is that patient will ask, so how long it will last? So you may provide several options to the patients, but patient want to know what's the difference between each of them and which one will be better than the others. So to get the information to tell the patient how long it will last, you will need to have a diagnostic criteria so you will effectively recognize the risk factor. Because if these options or a patient have more risk factors, that means that the treatment will be more difficult, the outcome will be no more promising, so you will less than ideal. So the classifications actually is to help us to do a diagnosis and treatment planning. And also it can indicate the increasing level of complexity. For example, if you look on the case I show you here, those 2 pictures are partial edentulous. Means that the patient lost several teeth in the mouth, and all on the lower anterior and posteriorly. However, if we really do a diagnosis, then we will figure out maybe the left-hand side patients have more worse prognosis than the right-hand side patients because the missing area is more and more complicated. So we may just say patient need partial dentures, but if we look on the criteria, that may give us the different opinion and the prognosis when we move on to the final treatment plan. So today I will introduce you the classifications actually is being published and reviewed on the Journal of Prosthodontics. This is a journal reviewed and published by the American College of Prosthodontists. This is a positional paper, so it means that all the prosthodontists actually follow this classification to do a diagnosis and definition. So as you can see here, this classification can provide us multiple purpose. For example, you can improve the consistency between the operators and also improve the professional communications. For example, like I showed you in the earlier slide, if we just tell to each other that patient need a partial dentures, but if we are not talk about it in the detail, it sounds like every patient will be the same, but exactly each patient is different. It also can give us several other purposes, but I think the most important for the students like you right now is that it will be a good method for you to do a patient screening. And the second is about this is good for you to know when you need to refer the patients. So when you really treat a patient in the clinic, you want to know how the prognosis will be and if you are able to handle this kind of cases. If it's too difficult for you to handle it, maybe it's a good time for you to refer to the other experienced dentist or the specialist. So this classification actually is be divided into 4 different criteria from class 1 to class 4. The class 1 is more ideal or just minimum compromise. The class 4 is the most severe compromised cases. So as you can see from class 1 to class 4, the difficulty will be increasing. And the diagnostic criteria actually is focused on 4 different fields. As you can see, one is about the location and extent of the edentulous area. The second is about the condition of abutment tooth. We also need to refer to the occlusal skin and the residual ridge. In the following slides that I will start to explain into the detail of each different criteria. So the criteria 1, the location and extent of edentulous area. In this part, it will include about where is the edentulous area. Is it just in the single arch on the maxilla or the mandible only, or it will involve into both arch? Also, it will involve into how many teeth are missing. So here, introduce you a new terms is about the span. So when we talk about the span in these classifications, we talk about anterior span and the posterior span. Anterior span means that is included incisor and the canine. The posterior span means that it's included premolar and molar. So not just included about the position or the number of the missing tooth, also will include which tooth is missing. So what type of cases that will be considered ideal or minimum compromise? If the edentulous span is just be limited into a single arch and also the missing numbers on the maxilla is less than 2, on the lower anterior is less than 4, then you will be considered this patient is ideal or minimum compromise. And also, if in the posterior part, if patient not missing over 2 premolar or 1 premolar and 1 molar, then they also will be considered will be ideal. So the second is the moderate compromise. The moderate compromise basically is the missing tooth is involved into the both arch, means that upper and lower arch both has the missing tooth area. However, the other following numbers will be the same as ideal. As you can see, if on the upper anterior shouldn't be over 2 teeth, lower anterior shouldn't be over 4 teeth. On the posterior teeth, upper lower is the same. It shouldn't be over 2 premolar or 1 premolar and 1 molar. However, if the missing tooth is the canine on the upper or the lower, then they will also be considered as a moderate compromise edentulous area. So the substantial means that the cases is get worse. As you can see, if on the posterior now patient lost more than 3 teeth or lost 2 molars missing, then there will be a substantial compromise. If on the anterior part or posterior part that is over 3, they also be considered substantial. So as you can see, if patient less than 2 teeth, then most of the time that will be considered as ideal or just a little bit compromised. But if it's over 3, then that will be substantial. The last one is about the severe compromised edentulous area. The definition is mentioned that any edentulous area or the combination of edentulous area requiring a high level of patient compliance. Be honest, I personally think this definition is a little bit vague because it's not unclear what's the what's a high level of patient compliance means for. So I will give you several like pictures to show you what type of issues may happen here. So here I will show you 3 different cases. As you can see, first on the left hand side, patient may lose a tooth, but it's not just about the missing tooth, it's about aesthetic. As you can see on the upper, patient keep the upper left from tooth number 9 to 11. However, patient lost from 6 to 8. So we know no matter we do implant restorations or to do partials, then we will hardly to mimic the right hand side to the left natural teeth. So for example, we still can restore this area, but it may cause more aesthetic issue for the patient. So sometimes we may think that's a little bit severe compromise because the patient really concerned about aesthetic will not satisfy with the outcome. The second one is about the space distribution. So this case, as you can see, lower anterior teeth is missing. Not fully, is partially missing. But as you can see, the space, you may find out that that space may be bigger than 1 tooth, but less than 2 teeth. But patient really lost 2 teeth. But so when you started to restore something over there, no matter it's a partial dentures or the implant crown bridge, then you have some issue is that you either make 2 small incisors there, or you may need to leave some space between each of the teeth. So no matter which options you provided, then that will be a issue to cause aesthetic and function. The third one may be related to the adjacent tooth alignment. For example, when we lost a tooth that for a long time, the adjacent tooth may migrated or incline to the edentulous area. So it will cause us more difficulty to restore the missing tooth area. So it's not related directly to the edentulous area, but it was also a little bit partially related to that and then caused us more difficulty to restore it. So if patient have those different issues and patient also have a huge like aesthetic or space distribution concern, then they will be considered this kind of cases is a severe compromise because your treatment outcome may not really fulfill their expectation. The criteria 2 is talk about the abutment tooth condition. So abutment tooth condition focus on is this tooth need any pre-pause treatments, or how about the prognosis about abutment? Is it poor or questionable? How's the health of abutment? Also, we will talk about the abutment location. So here I will introduce you another term, is a section. The section, as you can see on the right pictures, that the section means that we divided the upper and lower arch into 6 different sections. As you can see, from the premolar to molar, that will be 1 section. From canine to canine, there will be another section. So single arch will be divided into 3. So total will have 6 different sections. So ideal or minimum compromise abutment means that there's no pre-pause therapy is indicated. It means that all the tooth is good to go. However, if some abutment is insufficient tooth structures, then that will be considered maybe fall into the moderate. So this will be focused on that if some tooth is not in a good shape and how many teeth involved into the different sections. So the moderate compromise abutment tooth condition means that those poor prognosis tooth maybe just happens in 1 or 2 sections. So the insufficient tooth structure to retain a support intracoronal or extracoronal restorations basically means that those tooth may have caries, may have fractures, and eventually the remaining two structures is not good enough to hold the restorations. Also, if the abutment tooth needs some localized adjunctive therapy, for example, the abutment tooth have periodontitis, need a periodontal therapy, or they have a caries involving to the pulp, need endodontic treatment, or maybe the tooth alignment is not good enough for the restorations and need an orthodontic treatment. Those abutment need those extra therapy also will be considered as a poor prognosis. So the substantials means that those poor prognosis abutment involve into more sections. So if it's in the 3 different sections, then we will think about that's a substantial. So as you can see here, if it's over 4 or more, then that would be severe compromise. So in this abutment tooth condition, it was most likely to depending on how many sections involved for the poor prognosis tooth. The third criteria is about occlusal skin. So occlusal skin, it will involve into 3 different factors. One is about the tooth position related to the ideal occlusal plan, also related to molar and jaw relationship. The third one will be is this case involving to change of the vertical dimension. So if nothing need to be done, everything is okay, followed by the occlusal skin, and patient is a class 1 molar and jaw relationship, that will be considered as ideal or minimum compromised occlusal skin. However, sometimes we will involve into the cases is that the tooth will need to do some localized adjunctive therapy because they involve into the occlusal skin problem, like enamelplasty or premature occlusal contact. So let me explain what's going on here. So as we know, patient lost the tooth. So when patient lost the tooth, but they are not really received the treatment earlier, then the opposing tooth lost the support. So the opposing tooth was started to extrude it. And if the opposing tooth is extruded too much, they may involve into the occlusal skin. For example, as you can see on the slides, I show you cases that I treated before. So we know the lower occlusal plan is determined from the canine to the molar to the retrieval pad, as you learn in the complete denture cases. So we can draw a line. As you see, I use a yellow dot line to show you what's the ideal occlusal plan. However, as you can see, the tooth number 4 and 5, actually the crown is super erupted. So part of the crown is over the ideal occlusal plan. It means that if we want to restore all the missing area back to the normal, then the upper tooth number 4 and 5 may need to do some enamelplasty to correct that problem. So this is what cases will be considered the moderate compromised occlusal skin. However, if this involves into more teeth, as you can see, the moderate one maybe just involve into 1 or 2 teeth, but if the total arch need to correct that, so entire occlusal skin needs to re-establish, then that will be considered as a substantial compromise cases. Or if a patient has a class 2 molar and jaw relationship, they will be also considered as a substantial compromise occlusal skin. So what will be considered as the severe compromise occlusal skin? So if this occlusal skin need to be changed and eventually you need to change the vertical dimension, then these cases will be considered severe compromise. Because we do know that if we change the vertical dimension, then it will not just involve into the tooth. It will involve into the muscle, it will involve it into the temporal mandibular joint issue. So that will cause the prognosis more not promising. Also, if a patient is a class 2 division 2, means that the patient is a class 2 and has a severe overjet, or is a class 3, those cases also be considered very hard to deal with. As you can see on the pictures I show you here is another of my cases in the past. So you can see when patient really bites down that the lower implant's abutment actually is pretty close to the upper posterior teeth. So if we want to restore, no matter it's a partial dentures or the implant crowns there, then we have no space to restore it. So eventually I have to raise the occlusal vertical dimensions to increase more room for us to restore it. So this type of cases will involve into the total occlusal skin restore. So the lower and upper anterior teeth, even though it's no issue, also need to have a real restoration. So this will be considered as a severe compromised occlusal skin. So in the school, if any patients will need to change the vertical dimension to get the final prosthesis, that we will think that's not a student case in general. The last criteria is talk about the residual ridge. I marked the start here to say here we use the same criteria as a complete edentulism. So we'll talk about the partial edentulism cases, but we also have a complete edentulism classification. So here we use the same criteria as we described to the ridge part. So for the residual ridge, we want to get several informations. So first we have to get the mandible ridge height from the x-ray. And also we want to know the maxillomandibular relationship and how the residual ridge morphology will looks like. And the last will be where is the muscle and the frenum attachment locations. Is that affect the prognosis of a restoration? So first, let's take a look for this cases. This is be considered as ideal or minimum compromised residual ridge. So if the x-ray shows you the mandible still have over 21 or more millimeters height, then that will consider as an ideal lower residual ridge. If a patient is a class 1, also be considered ideal and minimum compromised ridge. The most important to evaluate the ridge is to look at if a ridge morphology can resist the horizontal and vertical movement of your restoration. For example, you can see this bone still have several height. So if we consider about the lateral force, that can resist those movements. Also, the location of a muscle and the frenum attachment, as you can see, is still a little bit away from the ridge, means that we still have a plenty of room to restore it without having interference. The moderate is talk about if the lower ridge started to have some resorption. So if the height is less than 20, between 16 to 20, then they may consider as a moderate compromised residual ridge. The maxillomandibular classification still will be the class 1. If a residual ridge still able to resist the frenum attachment, just a little bit affected, that will be moderate. As you can see, this case is showing here that the lower lingual frenum actually is a little bit attached over the ridge. So we know that we may need to do some compensate treatment options there. However, if a ridge keeps resorpted, for example, if the lower mandible is less than 15, from 11 to 15 millimeters, that will be the substantial. And started that the patient is a class 2 or class 3, that will be considered as a substantial cases. So in this type of ridge, you still can see a ridge form, but it's pretty shallow. So it's hardly to resist the horizontal and vertical movements, and also have a moderate influence on the restoration stability and retentions. So this will be considered as a substantial. So what the severely means like? The severely means like most of the time when you ask patient to open the mouth and you use your mirror, first, you will not be able to define where is the soft tissue, where is the ridge, because ridge is almost totally resorpted. You only can use your finger or the oral mirror to touch it until you can feel the bone. So those kind of cases will be considered that's a severe compromised residual ridge, means that you don't have anything can retain by ridge, or will be just retained by the soft tissue. So if we piles up all the criteria together, that will comes up into this chart. And you can use this chart to mark the patient's classification in different field, and comes up to say what the patient belongs to the classification. Some additional guideline here is that the most important is to know if a patient diagnostic criteria overlap 2 or more classification, then the patient will be placed in the more complex cases. For example, so we have 4 different criteria. So maybe patient have 2 criteria is be considered as ideal. So that's a class 1. But if the other 2 is be considered substantial compromise, the class 3. So how you define the patient? Patient have some class 1, some class 3. Overall, you will choose the worst one. So you will say patient is class 3, even though they have some criteria is class 1. So that's why we said if a patient diagnostic criteria is over 2 or more classes, then the patient is placed in the more complex class. Also, the consideration of a future treatment procedure must not influence the choice of diagnosis level. So, for example, you may extract the teeth out, but so far, when patient walk in, it's still not really extract the teeth out, so you will still consider that tooth is there. The third one will be initial pre-pause treatment or adjunctive therapy. For example, is also perio or endo treatment can change the initial classification level. So classification need to be reassessed after those existing prostheses are removed. So this is related to the second additional guideline. So when you do initial diagnosis, you're depending on all the tools in the mouth. However, after you do some treatment, what we call the phase 1 treatment, to treat the perio, to treat the endo, to treat the caries, those phase 1 treatment finish, then the tooth condition may change. So when the tooth condition may change, then you will need to redo the evaluation again. The classification may be changed or maybe still be kept or get worse. But no matter what, after you finish the phase 1 treatment, you have to reassess the diagnosis because the condition is different from the initial. The last two is talk about a patient have any aesthetic concern, even though they are the class 1 or 2, you will rise directly 1 level. So if patient is all class 1, but patient have a high concern about aesthetic, then you will say this patient will not class 1, they will be class 2. Also, if patient have any TMD, the temporomandibular joint issue, then they will also rise the classification. So, for example, patient said, oh, I have a clink sound of my joint when I open it, or I have some issue, I feel pain when I wake up, then it may have some like a TMD problems, then you will need to rise the classification. So those will be the additional guideline that will affect you to say what the classification patients really have. So in the following slides, I know may not easy to get on. So let me give you some example to show you how you use that classifications. So in this first cases, as you can see, okay, so let's take a look in detail. So for the location and extent of edentulous area, okay, we can see the upper teeth is no missing, only missing on the lower teeth, and missing tooth just only one. So we can say that's a class 1 because that's just limited in a single arch, and then the missing tooth is less than 2 to 4 teeth. So that's class 1. So how about the abutment tooth? X-ray really shows that everything looks okay. There's no additional caries. Intraorally also not really show us any caries existed. So we can say there's no further treatment needed. That's why we still say class 1. Occlusal skin, as you can see, tooth is not over erupted, so still follow the occlusal plan. So it's class 1. Residual ridge on the occlusal, you can see still prominent. You still have a pretty height, and also X-ray shows you still have a plenty of bone, so not severe resorptive. That's why these cases will be class 1. So overall, how you do the classification for this case? There will be class 1 because all belong to class 1. Okay, let's look at the second case. So we look at here. So first you find out, oh, patient missed tooth number 14 and also missed some lower right side tooth. So it's involving to 2 arch. So you definitely can say, okay, that's moderate, right? Because it's involving to 2 arch, not just a single arch. Abutment tooth condition, how the X-ray shows. X-ray seems to be okay. There's no caries. That's no periodontal issues. So it's be considered as class 1. What about occlusal skin? When patients bite down, you can see upper teeth still okay. They were not over erupted on the opposing tooth. So you don't need to do any enamelplasty. No further treatment need to correct the occlusal skin. So it will be considered class 1. Residual ridge. So upper looks fine, but if you look on the lower, you can start to see that's a little bit resorpted in the middle of the ridge. So the ridge is not flat. Right now it's like a U shape, means that that's something missing. So that will be considered as a class 2 on here. So how we define this case? So patient have 2 class 1, 2 class 2. So eventually we'll say this patient is class 2, correct? All right. So in this case, let's take a look. So we see, okay, upper anterior have some missing area, so it may involve into some aesthetic issue. Missing tooth is involving to several areas. As you can see on the upper, tooth number 3, 5, 14 is missing. So it's involved into right and left. And also on the lower, also have a multiple missing area. As you can see, that lower right is missing the premolar and the molar. Also the left hand side, the second molar is missing. So as you can see, these cases involve a lot of like missing tooths. So that's why we said this is a class 3. How about the abutment tooth? So you see that's a huge restoration overall, and X-ray and intraorally can see some restoration actually have some secondary caries around, and also some periodontal issue is involved into several abutment tooths. So eventually we'll also think this is substantial on the abutment tooth condition. How about occlusal skin? If you look on the picture B, when patients bite down, how you feel that tooth number 5? You know it was super erupted, correct? Involving to the occlusal plan on the lower. So if we want to restore it, then we may need to do some enamelplasty. And also on the left-hand side, as you can see, that first molar on the left-hand side on the lower is a little bit meso-tilting because the tooth is missing and it's not be treated instantly, so eventually the tooth migrated. So those missing area also will cause you, the problem is that you will need to do some correction. So overall, the occlusal skin will be considered also be substantial. How about the residual ridge? So upper looks okay, lower, the same as we see in the previous patients, is a little bit knife edge, it's a bit resorpted. However, it's still remaining plenty of a bone as you see on the x-ray. So we will say that's class 2. So in these cases, that we will say this patient is class 3. The last examples that to show you is most severe cases. So we take a look, we see, okay, patient lost almost all the prostheses on the lower, both sides, so missing more teeth. So that's a class 3. And abutment tooth condition on the x-ray shows you some crown bridge has secondary caries, so prognosis is not good enough. And also have some periodontal issues, so we will say that's a severely compromised, so that's a class 4. Occlusal skin, when patient bite down, you can see on the lower right and left hand side that the upper teeth not just only super erupted, also entire space is pretty small, so we will hardly to restore any restoration there if we keep this vertical dimension. So overall, these cases need to change the vertical dimension. And remember I said, any cases need to change the vertical dimension will directly be considered as a class 4, the worst scenario. And if we look on the residual ridge, so on the lower right hand side, you can see that's pretty flat and also not really have enough height to retain any restorations. So that will be also considered as class 4. So in these cases, patient have 1 class 3, 3 class 4. So we should use the worst classification. So we will say this patient is class 4. Is a severe compromised cases, hardly to deal with. So I already introduced you the classification that the prosthodontists used to do a diagnosis, and then in the following I will talk about how we do a treatment planning. So first, why we need a treatment planning? So treatment planning is about the framework for your treatment. As just like if you want to build up the house, you have to design and to know how it will look like. So the same, when we do a treatment planning, we have to have our goal to say, okay, so how can we solve the patient's problem? So in the treatment planning, it will include the target and contingency options. So it means that you may come up with several treatment options because some option may be ideal, some may be a bit compromised. The reason we still need to provide those compromise options is not because we want to do the case in compromised way, is because some patient may not able to afford or to go through those ideal treatment options as you provided. So the treatment plan should be realistic. Remember, you are not just only treat the tooth, you are also treat the human. Each patient have different situations. So you may say this patient need the partial dentures or need the implant restoration. But they definitely different from the other patients also need the same treatment options. So you have to really understand how the patient's conditions and how they reacted to your treatment planning. So it related to your knowledge, it related to your training and experience, also your principle of care, and then any material or procedural response. So you have to have all the detail to come up to a realistic options for the patients. So our goal or aim of the treatment planning procedure is to determine an appropriate short, medium, and long-term outcome which are acceptable to all parties. So when we comes up the treatment planning, we have to have some data. For example, when you look on the dental history, so if a patient walking in the clinic already have an existing restoration, and now that existing restorations or the dentures or the crown bridge is not able to use it anymore, the first thing is to know how long has the patient been wearing that. Are they have any complaints? The complaint means that is it fit? Is any aesthetic concern? And when will be the last time you will service? Sometimes some patient walk in and said, oh, I have a denture before. And you started to ask them, so when you have that? They say, oh, I have that 20 years ago, but I never wear it maybe 2 years ago. So you know patients is in a different situation because they may not like that anymore, so they don't wear it. So overall, in the dental history, what you really want to know, you want to know how patient reacted with existing one. So what's the problem that existing one bring to the patients? So then you were able to come up to say, okay, if I able to solve it, or I will still remain the same issue. So you can explain to the patient, be sure patient is on the same page. Because when patient receive a new treatment plan, they think, okay, now I will have a new restoration. Everything will be solved. But if something is still not able to be solved, they will disappoint with your treatment. So you have to know the detail and to tell the patient how you can solve that or why you're not able to solve that. The second part is also included the tooth and oral examination. You have to go through all of those. I know you already have some practice in the clinic, so I will not too focus on here. I'll just listed those for you as a reference. So as you can see, from different aspects, you will know how the occlusion looks like, what the abutment condition looks like. So you will devote it to how you do your diagnosis. You also need to have some radiographic. So X-ray tell you how the abutment condition, also tell you what the remaining residual ridge looks like. So overall, to give you the idea about how to define the patient classification. Periodontally, you will do a probing, charting, you will record it, each individual teeth. So eventually you also know the abutment tooth condition. And the final one is about the mounting diagnostic cast, which is very important for you in the clinic. In the school, actually, all the cases you will be treated, you will be asked to do a mounting diagnostic cases in most of the cases. So why we need to do a mounting diagnostic cases? So when we do a cast mounted, we will not just know where is the missing tooth. It gives us more better idea how the occlusal plane looks like, how they related to the jaw and dental relationship, and how the residual ridge height and interocclusal space. So it can tell you where is the edentulous area, how the occlusion looks like. Is it involving to the adjunct therapy like enamelplasty, or is it involving to change the vertical dimension? That will give you a different classification, correct? And then the final one is to see if any tooth is tipping or rotated. Until you have all of those, I want to more focus on this slide to talk about the patient concern. As I mentioned earlier, you are not just treat the teeth, you are really treat a human, a patient. So the patient concern actually will be the final determining about your treatment outcome. Because maybe for the tooth itself is the good, the best, but a patient may have other concern to cause them doesn't like that outcome. For example, economic. So when we comes up the ideal treatment planning, sometimes we may comes up very complicated treatment plan. However, patient may not be able to afford it. So if patient not able to afford it, then you need to do some cheaper options. Those cheap options may be a little bit compromised, so they will cause some concern. So you have to figure out what will be changed, what the outcome will be changed, and explain detail to the patient so patient can understand and accept that. Also, as I said earlier, amount of discomfort. So if patient have a bad experience in before, then you need to figure out where it comes from. For example, patient may say, "Oh, that denture, that partial is hurting." And when you do evaluations, you find out the ridge is very flat, so you have no room to improve that. So even though you make a new denture or partial, you may still talk about to the patient to say that will still cause some discomfort. It will be a little bit better than the previous one, but it will not improve all of that. The third is about the length of treatment time. Well, when you treat more complex cases, it definitely takes longer time. So some patients may not able to afford that because of their work, because of their social status. And in the school also will be related to your clinical time because you only have 2 years to graduate it. So if you treat the patient in the school, you may not want to come up to difficult or complicated treatment planning because you may not able to finish the case on time. The fourth and the fifth one is about aesthetic and function. As I mentioned, if you found out patient have a concern about aesthetic, about the functions, you definitely need to know what's going on. Are you able to solve that? If you are not able to solve that, you have to really talk to the patients, tell them that what's your limitations. So they will understand and eventually they can accept that. But if you don't tell them, eventually those issues will still be existed. And finally, they will say that treatment outcome is not good. It's not successful because they don't like that prosthesis. So hopefully after today's lectures, you will understand how to do a diagnosis and the treatment planning from the different perspective. So in the school, actually, we're treating you to do interdisciplinary treatment planning. So you definitely will work with different specialists. However, I think the most promising results still coming from the students. If you are well prepared and then to know how to do a data collection, to do a diagnosis, and to come up a good treatment planning, eventually the treatment outcome will be good. So hopefully you understand all the concepts I introduced you today and then use them in the future when you're in the clinic.